years ago, we're really in the midst really in the midst of a lot of community reaching out. And one of the, obviously CCM, we always remember that, but back in 1994, Dave Lockhart and George Lyles, members of this church, started the Community Free Clinic. So I'm delighted to introduce you today to Nancy Litton, who is the current director of the Community Free Clinic. She came in 2017, right? Mm-hmm. 2017, and that's when we met, and she became the director 2 years later. So this is her, January was her 5th anniversary, yeah. And so also Nancy was a key part in developing Racial Equity Cabarrus. She was on the steering committee with me, and so we've been working along and staying in contact with one another during that racial justice movement. So again, Nancy came in 2017, director, and now she's going to tell us about the needs of the community, particularly those this is about health care, of course, particularly those who have little or no health insurance. So, Nancy Litton, we're delighted to have you. Thank you.
Thank you, Chuck. Thank you. Okay. I do tend to be a little bit of a pacer, and I'm going to try not to do that because I know when you're presenting and it's on live stream, that becomes a challenge for the folks in the AV area. But I cannot tell you how excited I am to be here, to be in front of people and to be able to see eyeball to eyeball with folks and begin some of that community conversation again. I'm also particularly excited to be here because of the long-standing partnership that Community Free Clinic has had with All Saints. I'm going to have a chance to probably count off on my fingers and get to another hand on the number of ways in which we've worked together. But I know for today, you all are interested in me sharing a little bit about the people we serve and what Community Free Clinic sees as our patients come in and out of our doors. I'm probably going to do a little deep dive into the free clinic about process, I hope more so than just, statistical this and that. I've brought a couple of things with me today, one of which is a resource that'll be up on the screen when I'm ready to talk about that, which is poverty limits and how it is that the Community Free Clinic has identified and gives assistance to people at particular levels of household income. Now, the other item that won't be on the screens, because as technology savvy as I like to think I am, I'm not, which is, to put an up and down document in a PowerPoint that goes left and right. Couldn't do it. It was this nice little jumble that I could see, but I've brought with me today in a heartbeat, which would be a snapshot of how we did and what we were involved with last year. Now, I like papers, so I brought papers, and you're welcome to take them with you, and if you don't, that's fine too. But I want to also share with you a little bit about myself. So Chuck mentioned that I have been a part of Race Equity and was really excited to get to do that back in 2016, 2017. But I'd like to take you all a step further in my life and explain a little bit about my added decoration around my neck. Back in 2014, one of the things I had the privilege of doing is attending a National Assembly for United Methodist Women, and I was able to really do a deep dive into a program called Deaconess and Home Missionary. And I learned about it, I pondered about it, and I share this with you because it's a little bit related to your all's study these past many months and the ones going forward. A big step of the Deaconess Home Missionary Program is discernment. So I discerned, and I discerned. Well, the purpose of Deaconess, or the purpose of United Methodist Women, is love, justice, and service. And I am a Methodist woman. I am a Methodist, and we always have these sets of threes. But prayer, love, service, or justice and service are three things that are really important to me. And I sort of carried myself through discernment by trying to determine where my best place was. Now, the reason I'm bringing you this has to do, one, with discernment, that we do stop and think about things. Am I too garbled? Am I better? Okay. And let me know if I start screaming, because Chuck, I'm really loud. And that could be painful for folks. So discernment, kind of an important thing. I'm wearing my stole today because I'm just a couple of months away from completing my walk and my process of becoming an official deaconess in the United Methodist Women. Which, if you aren't a United Methodist Women, you won't know, we've just recently renamed ourselves Women of Faith, the United Women of Faith, in order to help us focus on what our guiding instrument might be, which is our faith. So I'm really excited about that, and I say a couple of months because in May I'm going to go to my official thing. I'm going to get sprinkled or shouted out or praised about or what have you. And I'm excited to wear my stole just because, one, I feel like it's appropriate here. And second, you might find a reason you want to interface with me in the future around things that don't always have to do with the clinic, but may have to do with your walk here at All Saints Episcopal. So in the spirit of that, I'm going to start us off with a little bit about devotion. Does anybody in here read the Upper Room? Sometimes. Okay. Well, yesterday and today were pretty relevant for today and my presence with you. So I want to share with you a passage. The thought for the day, God desires to know me completely. This was yesterday. This was Saturday. And the scripture is Psalms 139, verse 23. And it reminds us that the deep searching can be reciprocal. Not only do we have opportunity to explore God, but God desires to search our hearts. God loves us and wants us to be immersed in our hearts and minds. While the Almighty can do anything, God first wants our permission for this relationship. And I think if I take you all back to the beginning, and somebody's going to have to help me because I am not good with words. Tell me again the process. How am I pronouncing that, Chuck? Koinonia. I've got it spelled out, but I didn't want to test. I have to pair it. So as you began that process with Koinonia, I know what you were looking for first was the relationship that would guide you and bring you more awareness of your relationship with God, as well as God's relationship and work in your work. So that's a little bit of me coming to you to just say, I think this is a wonderful program and plan that you all are working on. So let's talk about what's relevant with the Community Free Clinic in that regards. So one of the things that I'll remind you is the clinic is now in its 28th year. Think back where you were 28 years ago. And for some of us, it's going to tug a little because think back on who was with us 28 years ago and what all has transpired. So the Community Free Clinic exists to really move people from the emergency department into a relationship with a physician, with a provider. The healthcare environment in 1994 was that we were seeing lots of people manage hypertension, diabetes, chronic conditions by just waiting until they got into a crisis and going to the emergency department and letting it be taken care of there. And all of the physicians, Dr. Mark included, that were in this community, recognized how not just was that ineffective from a cost standpoint, it was ineffective from a humanity standpoint. Folks were really pushed to being in crisis and then needing to have more assistance or more engagement to be able to bring things back to a status of normal. So the Community Free Clinic, modeled after lots of clinics across the country, across the nation, came into being. We weren't always across the street from you all, but we were driven by that volunteer spirit that you all are looking to engage in yourself with working with your community. For probably half of the 28 years, we were volunteer driven. Anybody and everybody who laid hands on a patient was there as a volunteer. And that's doctors, and that's nurses, and that's registrars, and that's the person who did the run-in between one room to the other. You know, the LPNs, the RNs, whomever, everybody was a volunteer. A particular practice would probably shut down at 5, go rapidly to the clinic, and reestablish themselves ready to be that volunteer resource for the Tuesday or the Thursday evening that they had volunteered. About 14 years ago, the clinic began employing a provider, a nurse practitioner. And that nurse practitioner then became the stability for the clinic in terms of that regular routine entity that would always know a patient, would know them closely and know them in the degree that was needed for really making a provider and patient relationship. So at that point, we began to shift a little bit, and we moved from the evening hours to the daytime hours. And now the clinic is really Monday through Thursday, 9 to 5. We have one evening clinic a week, but really Monday through Thursday. So I need you to kind of understand that when it comes to opportunities to work with us. You know, in many cases, you might be able to help us with expanding or exploring those evening time frames again. Or maybe helping us with expanding what volunteer opportunities we have by making some of those available outside of 9 to 5. Now, I'm going to take a pause, and I'm going to ask if we could look at a very short clip of video that's just a quick overview about the clinic. And I say very short because this is just a segment out of a longer video that you would find on our website, on communityfreeclinic.org, if you wanted to listen to the whole thing. But if we could pop that up. We are the health care resource for adults in our community who are without any health insurance, who are actively looking for a medical provider, as well as pharmacy resources.
We do everything we can to not turn anyone away. I mean, some people come straight from the hospital and they've just been discharged from the hospital or from the emergency room and they have no medications. So, you know, it's kind of hard to turn away a diabetic with no medications. We don't do that. We do our best not to.
When people want to try to take care of their own health and unfortunately can't afford it, this place helps them and it gives them back a bit of their self-esteem to make them feel a little bit more productive for themselves.
Okay, very short, very sweet. I wanted to introduce you a bit to the clinic for you to also appreciate that we're a family. We're a body of people who work together. In that video, you saw yours truly. You saw one of our providers. You also saw some of our patients, and you saw one of the individuals that's on our patient advisory council. What I want you to take away today is to know that the free clinic is where people who have no insurance can get help, where they can engage with a provider on a regular basis to be able to get that counsel and direction about how to take care of themselves. We're the place where when somebody needs medication to support that plan for taking care of themselves, that we can facilitate that as well. The clinic employs a pharmacist. We can literally hand medications over the counter, but more importantly, we have a partnership with North Carolina Medicist and with private pharmaceutical groups that do patient assistance programs or medication assistance programs in which they offer free medications to individuals that meet certain criteria. So now I'd like to talk to you a little bit about who exactly will be at the clinic. We'll have an adult, not a child, not an infant, and we'll have an adult who is battling a chronic condition. We are best positioned to help someone with diabetes, with hypertension, with COPD. We aren't prenatal care. We aren't postnatal care, and in many cases we aren't maybe some of those things that you think about when people are really in crisis. The clinic is not the best place for managing somebody's cancer path or the associated needs around Alzheimer's or dementia. We work again in partnership with the other specialties and resources that provide those things. But if you happen to be somebody who needs just basic, I need to see a physician, I need to keep my medications going for these chronic conditions, somebody who needs that support to help them then net together the types of other community resources that might be valuable for you, and you are uninsured, and quite honestly, you're at that lower end of the household income spectrum, the community free clinic is also the place for you. So when I talk about these individuals, I want you to know, inside of Cabarrus County, the community free clinic last year saw 347 people who met that criteria. They were an adult, they had no insurance, and they met our financial criteria. I'm really excited to tell you that we started 2022 by raising that financial criteria. And if you want to go ahead and pop up the federal poverty lines or limits on behind me, I just will share with you. The clinic was started meeting family needs at 125% of poverty. But this year, we have jumped to the 200% of poverty. And that, for a second, I don't mind if you do a little mental math or you do a little calculations. And I want you to think a little bit about what's your household size right now. Some of you might be one person, you might be two people. I want you to notice that 200% of poverty for a household of two is just over $36,000. That may seem like a lot, it might seem like a little, but it is the limit that we acknowledge that means a person would need financial assistance in meeting their health care needs if their household is at that income level. And just to help you understand, household is really the people who live in that home together as the household lead and their dependents. So if I'm a single individual living at home, obviously in my own home, I'm a one-person household. But if I happen to be a grandmother who has 3 of my child's children living inside of my home, and I'm fully dependent and fully obligated for their care, I'm a household of 4. But if I happen to be 2 adults who are just sharing space, then I'm still just a household of 1. You know, we're looking at something that's a relationship. And I'm sort of sharing this because I think sometimes people worry that folks are sliding in under the rug. You know, they're getting services they shouldn't. But I promise you, the folks that we're taking care of are really already out there committed to taking care of their families. Because when I describe the grandmother with 3 children, maybe even the grandmother with a child and their children, that is not an unlikely incident for the Community Free Clinic's profile. So now I really just want to tell you a little bit about what we see people need in the healthcare arena when they are part of our patient panel. Folks, they need to figure out how to access and take care of their life issues. Okay, I want you to stop with me a minute and just think about your morning routine today. You can give me a show of hands if you want to, but who in this room needed to take a medication this morning because it's prescribed, it's routine, and I need to have it? Okay. How many of us could conveniently walk into the bathroom or the kitchen where the medications are stored, know that they were going to be there, pop them out of the bottle, get a glass of water, and take them? How many of us had to prove to somebody what your household income was in order to have those medications in your home? Seeing a little bit of activity. How many of us had any concerns that we would not still be at the place we were yesterday to be there to have those medications be where we needed them to be to go and get them? How many of us might have needed to rely on a bottle of water in a backpack, in a satchel that we've carried around all day yesterday in order to be sure we had something to swallow it down with? Our patients at Community Free Clinic in this environment of income are really facing a lot of challenges. They really are. And I think any of the programs, any of the activities in our community that are helping to support stabilizing housing, making public transportation available, sharing a space of grace with someone in order for them to be able to take advantage of what our resources are. All of those things are extremely important for our Community Free Clinic. We're pretty good at doing the medical care. Now, any of you in here with a license behind your name, we're looking for you. If you're a physician, if you're a nurse, if you're an LCSW, if you're a dietitian, we're looking for you to sit in a clinic room and actually give care to our patients. We need that. But the other thing we need, our patients need, they need support. They need folks who are there with them as they go through this walk that's a little bit difficult. So you don't get to be a patient at a Community Free Clinic unless you have gone through an application, you've had all of your support documents looked at, and you've met all of these markers I talk about. You live in Cabarrus County, you're an adult, over 18, under 64, you've got a household income under 200% of poverty, and you are uninsured. And you know, we need to know that because that's our criteria. And in doing that, we sit across a table with somebody and we look at things like their verified address, be it a driver's license, a bill that's arrived at their home, those sorts of things. We talk to them about what their circumstances are to gain an understanding if they're truly uninsured. Because over 18 is because children can get Medicaid under 18. Under 64, because if you're 65, you can get Medicare. But as we sit with you, we come to understand, well, I am 66, but no, I'm not eligible for Medicare because I haven't either worked in the workforce long enough, or I haven't been or I'm not a citizen of the United States, reasons that would disqualify you for Medicare. And the same thing can happen on the other end of the spectrum for children as well. But the clinic's better positioned to help people beyond 65 than we are below 18. So what I'm helping you to understand is the work that you do in this community is going to be beneficial for my patients, even if it's not done in my building across the street. But an example of a way that All Saints has supported Community Free Clinic, I'll take you back to pre-pandemic when we were a part of our lifestyle medicine program, providing folks with nutritional foods, giving them class instruction on how to live more healthy, get sleep, avoid sugars, all of those things. And this faith community opened up this room, brought people in here, helped them have food, prepared food, broke bread with them, and got to know them. So a couple of the things I think about specific to my patients, a person in particular that was with you during this was Layla. Layla was one of our patients. Layla was enrolled in lifestyle medicine. And Layla came and helped Dr. Nance and Greg and Alicia with making those programs happen. She was a part of the behind the scenes. And as a patient, that built self-esteem for Layla. That gave her a chance to not be in her house, in her environment every single day, all day long. It let her interact with people, and that became important for her. And she thrived in that environment. And I hope still does, but as you all know, with the pandemic, we had to backpedal and we haven't had those kinds of interactions in the future. So that's an example of a way that you all might think about what your path in service may bring you back to or may bring to a possibility for you. I also want to tell you about another individual who was very recently in the clinic for a relatively routine reason, but made some complaints about some things that caused the provider's ears to perk up and their antennas to wiggle a little bit. So a little bit more evaluation, and we discovered, unfortunately, someone who is probably facing a terminal condition. And what the clinic had to do was step into full gear and be able to call first this place, and then that place, and then the next place. And we had to connect her to the first line of evaluation, the first set of diagnostic activities. And then when those were learned about, then the next thing that needed to be done. And I have a little Post-it note of the days of the week, the dates of the month, and what all got ticked off. Inside of 10 days, this individual went from having no clue as to what she was dealing with to being in pretty much a complete plan of action for what could be done for her particular situation. So again, relationship and building community, being able to connect things. And that's an important part of what our staff has to do, but it could be maybe a way that this church could be interfacing with our patients as well. These are a little bit vague examples for you, and I can realize you're thinking, well, Nana, really, what can I do? I want to come show up, I want a task, I want to do it, and then I want to be finished. And that would be helpful. We need people, as I call it, upstairs, who spend time with folks and help decipher these particular things that folks are looking to deal with, and then help them make those connections. The upstairs work versus the downstairs work isn't as much about license and credentials, but about heart and about connectivity. And yes, I do know that CCM does this on this Thursday. By the way, the food pantry is now open from 3:30 to 6:30 on Thursday. Did you know that? To be able to make that connection happen. Or to be able to sit in conversation to realize, I keep hearing her talk about how she can't take her medicine, but what she's really never getting around to telling us is she's living in her car. Or, you know, she's taking care of these other individuals who are distracting her from taking care of herself. Okay? Now, I'm very much aware of how much I talk and how much I'm in love with the sound of my own voice. So I want to take a moment and pause just a minute to see if there might be questions that I could answer. I'm going to finish up today with another little bit of inspiration for you, but if there are questions that would be good for me to answer, I'll be happy to.
Back here in the back.
Nancy, how many people do you estimate in Cabarrus County fit the criteria of the population that you serve? How many uninsured people do we have?
We have. And it does need to be put into the box, because we've probably got about 10,000 uninsured. And probably of those 10,000, in the last couple of years before pandemic, that shrunk to more like 8,000. Now, it's probably ballooned back up since the pandemic. But some of those individuals have resources and have the ability to have their health care needs taken care of for them. Of the 10,000, there are probably 5,000 to 6,000 that really are in our camp. And the Community Free Clinic is not the only entity that provides health care. The federally qualified health centers, McGill and Logan, do so as well. So we kind of share some of our resources. They used to be at about 3,500 of the 5,000. We were at about 1,200 of the 5,000, which left us with maybe about 800 that we didn't know where they were.
I thought that there was a federal program now to make sure that everybody got insurance. Why are there still people that are uninsured?
In North Carolina, and let me back up to say, the Affordable Care Act was that vehicle through which we were getting people insurance. And that vehicle provided for personal purchase of insurance at a very low reduced cost. But there was also a component of bringing the extremely low income individuals into the framework of Medicaid. adults were being allowed to be a part of Medicaid. And in North Carolina, Medicaid is not something that we expanded. So in North Carolina, that option doesn't exist for adults. Unfortunately, it made for a catch-22, because if you happen to be an adult and you have super low income and you're on the marketplace trying to just use what little resources you have to buy insurance, you're going to get, sorry, you're not qualified. You should be enrolled in Medicaid. So that's really that's a donut hole for North Carolina that we still struggle with. Okay. Now, understand there are always going to be a body of individuals who won't have insurance for a lot of reasons. So I'm not trying to describe to you a way out of business for community-free clinic. We're always going to be needed. But and if I might get back to my numbers, the thing that we struggle with is we don't know. One of the first things the community-free clinic would like to do post-pandemic is start being in the community with our people, with our spokespersons, with the folks that know what we can do to share the message. And that could be the real benefit of you all working with us. Being in a place and a time to be able to share, oh, it sounds like you could benefit from the community-free clinic. Okay. Other question? I think Randy might have had, I've got one back there. Sorry, Randy, we'll get to you.
I just have a quick question. I do volunteer at CCM, and one of our clients came through this week, and they had dental needs, and they fit into this category. Is there an organization similar to yours that provides dental assistance?
The best organizational framework is Cabarrus Health Alliance's dental services. Unfortunately, through the pandemic, what structure that the free clinic had hobbled together for dental services sort of collapsed when we couldn't have people in the building being reviewed. But we have a body of individuals who do see a certain number of patients for free for dental services, a body of dentists, if you will. Their services are basically extraction. Maybe some other, but basically extraction. And that is a place that we need to build some depth and some additional resources in. Because if you are, as we call it, a pink card person, because our card is pink, our application is pink, and you do have a dental need, we will try to find a place to refer you to, but that's like we try to find a place to refer somebody for mental health services, for other things as well. So some improvement in that area is needed. Mm-hmm.
Nancy, I believe you mentioned 347 unique patients in your last year. Mm-hmm. How does that compare to pre-pandemic?
Okay. At the peak of our patient population, we had closer to 700 patients every year. Now, I'm going to be honest, our dental clinic, our screening clinic, brought people in that we were considering patients as well. We had some on-site specialty clinics that we were able to host as well. So we are basically at the halfway point than we were post-pandemic or pre-pandemic.
And what's the conversion in terms of 347 equates to how many visits or touch points?
It does similarly. At 700 patients, we had about 6,500 encounters. Mm-hmm. And with 347 patients, we had about 2,300 encounters.
And one last question. You mentioned getting out into the community. Are some free clinics now beginning to employ community health workers? And is that like, do you have one, or is it on the horizon?
It's on the horizon, and we have one at the same time. The Cabarrus Health Alliance has placed a community health worker in our clinic, and I have discussed with our enrollment team about repositioning, transitioning them into a role similar to a community health worker, as opposed to a paper pusher, a collector of documents. Let's make our document collections more streamlined, and let's get things automated, and then let me get you all more engaged in what we refer to as the social determinants of health. Let's figure out how to make our enrollment so easy that A financial assistance volunteer at CCM can get somebody enrolled, just like Laura at Opportunity House can get somebody enrolled. Let's quit chasing the documents and start doing more activity. So we have that on the horizon, if you will. Also the work of a patient navigator is in our sphere as well, because one of the things that's so important is to move people into insurance. Get them connected to the programs that have more depth, have more autonomy, have more dignity built into. You know, if I have to be the one to say you can go to this or you can't go to that, I don't like that. I don't want to be that person. And it's also more cumbersome if the third party has to do the arranging. So we want to try to lift the burden of doing for you. As I like to say, let's start helping people instead of handling people. Okay. Yes, Martin.
Nancy, I've worked mass vaccination clinics and mass testing clinics, and a lot of that with CHA and other things are moving more to business as usual. What is the community-free clinic's involvement in vaccines and testing?
A couple of things, and you all were a part of our couple of things. When the CHA became able to do more localized vaccine clinics, you all provided us the space in this room for us to host vaccine clinics for our patients, because we could not do drive-through, and we don't have this kind of open area in our clinic to be able to do that. So we hosted 2 vaccine clinics here. We were able ultimately to get about a third of our patients vaccinated at that point in time. The other item that we do that's kind of, it is a little bit back to business, but it's not. Our staff stays involved with a vaccine hesitancy professional development structure that the CDC and AmeriCares has sponsored, so that we're trying to use tools or tips that would help move a person from hesitancy to vaccines as well. We are reminding, we're promoting, we keep all of the resources where you can go for vaccines ready and available as well. I don't know how to say enough. Get stuck. Get stuck. Get stuck for the 4th time. Take somebody with you. But we are also respectful of individuals' choices. So we maintain a clinic structure that would allow that someone can get their care as they need if they haven't been vaccinated as well.
I understand you accept donations.
Yes, ma'am.
Could you elaborate a little bit on what kind of donations you would, want?
Well, today I might be speaking more directly to time and talent from individuals. And I'm going to go home and wish I hadn't said that, because everybody's going to be excited and you're going to want to come, and I'm going to go, oh, no, I don't know what to do with you. But I do. Time and talent. I mean, we get more done with partnerships than with anything else. I mean, the work we've done with CHA has been remarkable. The work we've done with Cabarrus Family Medicine, with the Cabarrus Family Medicine residency program, with Medicist, is remarkable. But we also take that hard cash dollar stuff, I'll take a check, I'll take a roll of quarters, I'll take whatever. I mean, there are things we can't do unless we have money. Really and truly. And we do take supplies and other kinds of tangibles, but it's a little less helpful for us to get the things that you're not going to use from your medicine cabinet or your past experience in healthcare than it was maybe previously. Because if your doctor has changed your insulin product and now you don't need that test kit or you don't need whatever, chances are real good our patients are getting changed as well. It's hard to really ensure that something has been repurposed well enough for equipment and such. So it's a little, we got a lot of walkers, we got a lot of, shower chairs, those sorts of things. So I would, but when a person isn't going to use insulin, we really would like to have that. When somebody has had their nebulizer change, especially emergency asthma. Can you tell I'm not really doing my brain very well? I'm sorry. Those sorts of things we need. They need to be in date and unopened as well.
Thanks for being here, Nancy. I'm aware that I believe we're one of 12 states that our legislature has chosen not to expand Medicaid, and I've been told a few years ago that came at the cost of $20 billion of federal monies that could have been spent on our citizens of our state. Two questions. Number one, is it still possible to expand Medicaid, or has that ship sailed? Question two, is there anything a faith community could do to urge our legislators to expand Medicaid?
Okay. Well, I'm not going to pretend to be the expert on Medicaid, but I do believe that the ship hasn't completely sailed, but it's definitely out of the dock, so to speak. We won't recover those funds that we didn't receive. I mean, that won't be possible. There does become a time and a place where some of those federally supported funds will just have reduced, and it will be the responsibility of the state to do. And again, I'm not an expert, so I'm not going to be specific in that respect. From what could you do? Well, as I was sharing about some of the ways you could engage with community health, with our community-free clinic, I want you to understand advocacy is one of those core fundamental items that we can all do. We found this with race equity. We've known this with other, if you will, systemic issues we've tried to address. You really just have to stay informed and talk about it. You have to have some bravery and continue to bring it forward. And I think as a faith community, we pray. We ask for guidance, we listen, we discern, and we move on faith as to what will be the words out of my mouth, so to speak. Find a chance to be in the presence of decision makers. It doesn't have to always be your senator, your congressman, your whomever, but somebody else who's influential. You know, it has baffled me that we didn't do that, but we didn't. So it's our reality. And I would love to be out of the business in the sense that the primary bulk of my patients would be in Medicaid, and then I could be working on some other things as well. Yes,
I have two unrelated questions. I just like your response to transportation being an issue or not. And do you have an eyeglass program?
We have worked with the Lions Club to get to eyeglasses. We've worked with them. And we have a lovely, very deep relationship with Cabarrus Eye Center. But no, eyewear is not really a part of what we do. When it comes to transportation, it really is so complicated. We have such good resource with a bus stop by our office, but that still doesn't take away the time commitment that it takes to be on the bus. So a lot of our patients are reliant on friends and neighbors, and can I get a ride, and will I borrow your car, and those sorts of things. I think any of the work we do as we continue to build capacity with our transportation system is important. The clinic gives bus passes to our patients so that at least that isn't a burden, that they have to pay for their bus pass. But that doesn't get them to the grocery store to get those fresh fruits and vegetables that we've told them that they want to do as well. Okay.
At this time, we're going to need to transition from our streaming so that we can set up for the 11:10, but that doesn't mean that we have to stop here. So let's go ahead. We've got Nancy with a question.
Thank you for being here. I'm learning a lot from what you're telling us. Do you think the Dr. Nance's program will be something in the future that will happen again?
If Dr. Nance is any indication of what's going to happen in the future, yes, ma'am, I do. What it will actually look like, I'm not really sure. I'm really sad that we spent 2 out of 3 years of a grant program in COVID, because we are going to be looking at how to continue that under different funding structures, so to speak. But Dr. Nance is a man on fire, and his lifestyle medicine program at home, he just keeps moving. He just keeps moving. So I feel like, yes, there will be. And when you have friends like that in your backyard, he happens now to be a member of our board of directors, then things do begin to happen happen whether you had expected them to or not. Just the other day, he asked me to identify a couple of community-free clinic patients that could be a part of his lifestyle medicine program at home as he lives as a physician in Cabarrus Family Medicine, really seeing people in which there needs to be a payer source and there needs to be, you know, all of that goes along with that. So I hope so. I hope so. We have continued the food pharmacy. We've done it in a drive-through model. We have a volunteer, Johnny Carroll, who coordinates and shops and gets all that together for us. The Health Alliance has continued to offer some of the classes that we've done in the past as well.